Okay, good evening to everyone. Today I am going to talk, my topic is central line management. So we are going to see introduction, indication, contraindication, types, complication, and nursing responsibility and management. So importantly, we are going to discuss about nursing responsibility of the central line management. Also, we are going to see the removal, documentation, and lastly, we are going to see the type of central line infections. So introduction. Central venous access is defined as a placement of catheter such that the catheter is inserted to the vein, a greater vessel. So mainly here, for the bigger vessels, the central line will be inserted. So it especially is a venous, it's not an arterial. For bigger venous vessels, the central line will be inserted. So which are the biggest vessels? Internal jugular veins, subclavian vein, bronchocephalic vein, iliac vein, and common femoral vein. So these are the veins where they will be selected for the using the central line. But when it comes to transplant setup, mostly we will use the upper part of the blood vessels, not the lower part. So femorals we are not going to use because of high infection. Generally we use the internal jugulars. Indication for central line, to whom all we need to put the central line, to whom all requirement of central line will be there. So administration of chemotherapy or vesicant drug. So such type of drugs if we are going to use, we may need central line. And also daily blood sampling if we going to do means such type of patients need the blood sampling, CVL insertions. Just a minute, some people are joining, I shall make them to join. And next is daily blood sampling. So whom they daily long-term blood sampling is there for such patients needs the central line insertions. Also, venous access need for long time. If somebody needs a long-term venous access for treatment purpose, so such type of patient also we are going to insert the central lines. And frequent administration of the blood product. If somebody need the so who is this iPhone? Can you unmute? Mute, sorry. Okay, then. Frequent blood product administration. So such type of patient also we will use the central lines. Also, if somebody needs a TPN, total parenteral nutrition, and administration of less than pH 5 or more than 9, such type of solution if you want to use, we'll use the thing. And administration of high osmolality medications. Also, somebody who need the CVP, central venous pressure to be checked. And if somebody need the inotropic long-term leg, and when we are resuscitated, again we have to continue the inotropic. So such type of patient. Hemodialysis, multi-therapies, and apheresis. So during the sometime apheresis also, if very smaller children, they'll put the central line, from there they will do the collections. Contraindication, if these all the problems are there, they are not supposed to insert the central line. Distorted anatomy, infection at the site of axis, where we are going to insert the site. In that side, any infections are there, that side we are not supposed to use. Proximal vascular injury, bleeding disorder, or anticoagulation. So especially in our cases where we are seeing the aplastic anemia patient, they will have bleeding problems, low plated. Such type of the patient, first we have to fix the thing. We have to do the sufficient transfusion, then we have to take them. Otherwise, during the low platelets, we cannot do the central lines. And venous stenosis or thrombosis. These are the main 3 types of central lines which we will see in our practices. So one is non-tunneled central line. In name only is there, the tunneled is not there, non-tunneled central catheter. Implanted. So in the further slides, I'm going to talk about this part. And other part is tunneled central catheter. So these 3 catheters, type of catheters are there. But important here, in all this type of central insertion, the site may be vary. In all this central non-tunneled chemo port or tunnels or catheters, the site may be different site may be there. But the tip positions always will be same position. You can see here SVC or lower part. So it will be there here. So this two part only, the tip position will be the same place. What is non-tunneled catheter? In the non-tunnel catheter, directly the catheter will enter into the blood vessel. The venous puncture will happen and directly it will go, especially internal jugular, subclavian, femoral, or upper arms. So you can see these images. The catheter has entered directly into the blood vessels, directly into the blood vessel. So here the problems are when it is directly entered with the blood vessel, the risk of infections will be very high. So especially in these areas, skin flora, any infections are there, easily it will enter into the blood vessel as direct access to the blood vessel here. So this all the thing are non-tunneled central catheters. So again, this is non-tunneled central catheter where subclavian it goes, internal jugular it goes. This is internal jugular, it is a subclavian vein. Here in the non-tunnel catheter, we will have single lumen, double lumen, and triple lumen. But this is for the very short time. If we are going to use a short time central lens, it can be used. Now, example, patient has readmitted, patient needs like short term some therapies, such type of time we can use this patient. But directly for transplant purpose, we cannot use these catheters. What we call PACC, peripherally inserted central catheter. This is also non-tunneled catheter where the catheter is directly entering into the blood vessels. So this also, if we are going to maintain properly, we can use for long term. But again, always the risk will be there whenever we are doing the dressing, whenever removing this placement will be misplacement will happen. Slowly the catheter will slightly come out. Again, staff will try to insert. So there is a chance of getting infections. So these all the risks are there in PICC line. This is called as a subcutaneous port. The subcutaneous port also called as a chemo ports. So this is will be used for the long term. If somebody wants to like more than year, 2 years, 3 years. So especially the oncology patient who is receiving the chemotherapies, such type of patient will use this one. How it will be there means you can see the chemo port will be the under the skin, not above the skin. It will be under the skin. The chemo port will be inserted and it has gone and it has been SVC. So this is the needle where whenever patient comes for chemotherapy receiving, when patient comes, so they will insert this one, give the medication and they'll remove it out. But here this catheter is no use for us transplant setup. Hardly in the transplant setup, we want at least 18 to 20 days before the transplant where we give the chemotherapy. After transplant, 20 days, hardly 40 days we want. So in this catheters, this is invasive, it goes completely inside. Removal is not so easy. So transplant purpose, we cannot use this one. So we saw non-tunnel central catheter, we saw chemo port. So now the last one, which I'm this slide is showing is a tunneled catheter. The tunneled central catheter, what we are using in our setup, that is also called as a Hickman line. So you can see in this diagram, the catheter has entered here. Completely it will go under the skin. So tunneled under the skin, and then it will connect to here internal jugular. It will connect to venous catheter. So this is the important part where the catheter directly has not entered into the blood vessel. After going under the skin, then here only it has entered. And next thing is this catheter has a cuff where the movement will not happen. Also, which will prevent from the infections and it will make to secure the line. And this catheter in our patients, you might have seen two sutures. One suture will be on neck and one suture will be on the this side in the chest wall. The suture which is in the neck area is called as a entry side suture. The suture which is in the chest wall, that is called as a exit side suture. So these are the two sutures will be. This is the way how the Hickman line looks. So overall, from three-part chemopod and the non-tunneled catheter and tunnel catheter, the best standard in the transplant setup is the tunneled catheter, which will be used. So after central insertion, this all the complications may happen, especially vascular, air embolism, arterial puncture, fistula, hematoma, blood clot may happen. Especially in our patients, the patient who has undergone the Hickman lane insertion, who has the low platelet. So patient with Fanconi or aplastic anemias, the platelets will be very low. There is a high chance to get the hematomas and bleedings will be there. So these are the things closely we have to monitor and we have to report to doctors and take a necessary action. And also central line, after central line, there is this risk of getting sepsis, arthritis, and cellulitis. And during insertion also there is risk of dysarrhythmia. So sometimes the guide wire may go too deep, or catheter may go deep, arrhythmia may happen. So this all the nerve injuries, pneumothorax, hemothorax, especially when the lower part, when they put the central and femoral areas, bowel and bladder injuries may happen. So this all the complications which will be happening. So we have to see if anything assessment, any problems are there, it has to be reported to doctors. So this slide, what I'm going to speak about the main important management, nursing management about the central line management. As a nurse, what I have to do. So first of all, the first part I have mentioned is the tip confirmation. Before the tip confirmation, I have to tell whenever, now I'm going to talk about more clearly about the especially in Hickman line management. So whenever Hickman line insertion as planned, at least before, it is a planned procedure, it's not an emergency procedure. So one day before, anesthesia evaluation will happen. Overnight, the patient will be on NPO. Before shifting the patient to theater, first of all, the skin care is very important. So we have to give chlorhexidine based scrub bath for patient. That is very important. Otherwise, still during the procedure only, the patient may get infected, and with the infected patient may reach to BMTU. So important part here, patient has to get the chlorhexidine based bath, because before the central line major line, nothing will be there. Patient can easily get the complete head to foot bath. Patient can take chlorhexidine based solution bath we can give. After that, the patient will be shifted to OT as per pre-medication, other things will be given. Patient will be shifted to OT. Always, especially for our patient, line insertion has to be done in the morning, because once operation theater starts, people will be coming and going, OT will continue, cases will be running. So if we take third or fourth cases, there is a high risk of getting infection from the OT, and it will happen. Because many of the our patient, especially aplastic such a patient, already the patient neutrophils be low, patient will be in the immunocompromised stage. So this insertion should not make another new problem for patient to get an infection from the OT. So this Hickman line insertion will be done under the general anesthesia. So once the patient recovery happens, the patient will be shifted back to our department. Once the patient comes to our department, we are not supposed to touch the line without the doctor's order. So first of all, we have to confirm the tip confirmation. So once we get the images from the OT, that images has to be shared with the doctors and get a confirmation to access the line. After doctor confirms it can be accessed, that has to be documented in the nursing note, who confirmed that one and that is accessible or not accessible. The next thing is about the pain management is very important. Many times when we receive the patient from the OT, so sometimes we will forget, the patient will be on bed, patient will be laying on, because during the procedure, patient has gone into general anesthesia, patient may not feel anything pain. After patients are getting recovered, because as I mentioned, this Hickman line, the subcutaneously under skin, the tunnel will happen. This procedure is the painful procedures. Especially the smaller children's, they cannot express the pain, and almost here multiple in the neck and chest wall, there will be multiple flashes will be there. There is a high risk the patient may pull out the line. So that's why once the patient comes to our department, we have to closely monitor, check the pain assessment, what is the pain level. If the patient pain is increasing, inform to doctor, give the analgesics. Generally, from the OT only, we will have the round-the-clock analgesics will be there, but we have to close the monitor at least 24 hours. We have to give the analgesic cover to the patient. Once the pain has cleared, the patient will not have any discomfort. If the more pain is there due to discomfort, patient may pull out the line. The next management is about the entry side suture. So in the neck, there is one suture is there. Generally, as per our SOP, it will tell like after 1 week of the procedure, we can remove the suture. But if the patient is not cooperative, if the patient is very small, then we can remove during the discharge, no problem. But if the patient is cooperative, no issues, we can remove this entry side suture after the 1 week of the procedure. The next management comes about the CVL dressing. About this, further all the topics I am going to talk in further slides. So as a nurse, once the central line dressing happened today, CVL insertion happened, the next day we have to do the dressing. From there onwards, every 7th day we have to do. And next part is ANTT technique and safe infusion practices are very important when we are handling the central line. And regular connecting tubes. So what are the connecting tubes we are using? So that has to be changed every 3 days once. And CVL patency, closely monitoring the infusion pump, syringe pump. So that's the heparinizing the lines. These all the things are very important. And CVL blood sampling. So sterile way, ANTT techniques, we have to do the blood sampling. The last part is documentation. For this, all the management, each management, the documentation is very important. What are the things we have done? It has to be documented. What are the things we have observed in the central line areas? That has to be documented. If anything concerning, it has to be reported to doctors. So overall, this all the above nursing management, what I told, the important step for this all the management is hand washing. If we want to maintain our central line very well, the basic important part is hand wash is very important in the team. And continuing nursing education is very important for staff nursing education and the attender nursing education. Why do we need to give attender nursing education? Central line infections will not happen only by the accessing the central line. The skin care also very important. Hygienic, maintaining the hygienic also very important. So whenever attenders, when you go to rounds, when you got to talk to patient, you have to check the patient has taken bath clearly, and is this neck area, this all the area, is it completely clear, is there? Because many times what will happen, the patient may sweat badly, the central dressing may become loose, the sweating may be entering inside, or patient may vomit on the central line side. So these are things. So hygienes are very important, and patient has to take thorough clear bath every day. About the staff is very important, especially the new staff joined to our team. We have to be very careful in these areas where because if somebody don't know how to access, they have to learn, they have to complete our checklist 3 times observation, 3 times with the supervision. Even though if they have experience in other hospitals also, they have to understand our SOP, they have to follow our rules. Then only it is very easy to prevent the infections. Lastly, the teamwork and doing the right thing when no one is looking. These 2 things are very important, because we have seen in our center, whenever we don't have any major infections, the workload will be very calm and everything goes very fine. Because when the patient comes to transplant, always we will think about what protocol to be used for that patient and what cell dose to be given. Equally, what cell dose, what condition regimen, equally the success of the patient, central line management is very important. If during the transplant period, if the patient is going to get any central line related infection, surely it's going to affect the result of the transplant. Many times, as per my experience, I have seen most of the patient who's got central line infection during the transplant. One thing, patient we have reached to ICU and we have lost there. Otherwise, patient has got rejected. So these 2 things only maximum what I have seen. So doing the right thing, especially night duties or evening duties when you don't have supervisors. So think, is it I'm doing the right way? Because by your one mistake, one unsterile handling, we may lose that patient and it may affect whole over the team people. So that's why we have to always be careful when we are handling the central line. Even though if you're busy, anything, if you're going to test the central line, be very clear. Segregate the work, what is important, what is non-important. Non-important, you can do anytime after later. Important part, do as a sterile way, that is very important. So here we are going to see the CVL dressing. So CVL dressing part, I don't want to talk more about that thing. Already you have gone into SOPs, everything. But important parts just I have to cover in this thing area. So CVL dressing will be done once after doing the central line incision. Next day we will do the CVL dressing. From there onwards, every 7th day we are going to do. But in between, if anything oozing or any bleeding is there in this side, so immediately that has to be changed. The bleeding oozing is coming, we can keep a small gauze piece here and we can do the dressing. If no oozing, no bleeding, do not use any gauze piece in this area, because every day we have to observe this area. Not only in this area, this all the surrounding area we have to observe where the patient has any pain, redness, anything. So if anything, observation, pain, redness, anything, if you have thing, it has to be documented and it has to be immediately informed to doctor. So if anything exudated, or if the patient has any chlorhexidine reaction on the skin floras, alternately we can use normal Solen. Also we can use the next option is betadine. So these two things has to be used, especially if patient has a chlorhexidine reactions. And next thing is, the important is how we are going to clean. The important, from inner to, we have to come outer. So we are not supposed to touch from outer to inner. We have to start with the inner to outer. So we have to wear the examination gloves, remove this old sterile, tagadam we have to remove, do the hand wash, all the required item has to be there, and start from inner to outer. So inner to outer maintaining very important. And after using the one gauze, if you have collected, if you have taken the one gauze, clean this area. Once you came outside, throw that gauze piece, take a new gauze piece. And here important part is, you're not supposed to hold the gauze piece with your hand. Even though if you're using the sterile most gauze also, you're not supposed to touch with the gauze piece with your hand. Always use the cetal forceps and the thumb forceps and the artery forceps. From the thumb forceps, you have to hold the gauze piece and you have to take the artery forceps and roll that one. Because even though if you're wearing a sterile also, there's a high chance to get infected, because you're going to test in your bare hands. So in the gloves also. So always use the cetal forceps and the artery forceps from just round that one and clean from inner to outer. And next part is, after cleaning this area, so we have to allow it to dry for at least 30 seconds. So hurriedly, we should not try to blow from our mouth, because in our mouth, lot of bacteria are there. If you're going to blow, all that bacteria are going to enter in this area. So allow 30 seconds. So after 30 seconds only, the chlorhexidine start working. When the moisture is there, if you're going to apply, the infection is going to grow that area. So completely that area has to be dry completely. Then only we have to apply the tagada. When you initially, before doing the dressing, if you see any oozing, any pus in this area, before cleaning that area, you have to take the swab, open this tragadum, take the swab, then do the dressing, and that swab inform to doctor, and the swab has to send for the culture. Always make sure the exit site should not be in a wet site. If wet is there, means the infection start growing. So these are the basic important parameters of the central line dressing. And also when we are doing the dressing, always we have to wear the mask. Also, if patient also, if cough, cold, anything is there, we have to ask patient to wear the mask. And always the patient face has to turn into other side. So here I am going to show a short video about the ANTT. What is ANTT? Aseptic non-touch technique. So about this, I am going to show a small video, just you can see. So key areas are very important when we are handling the central line, especially hub, where the when we are loading the syringes, when we are connecting the IV fluid. So that key areas we are not supposed to touch. So see, this is a key area where syringe and needle we are connecting. Our hand should, and we are connecting the IV fluid. That is a very key area. After cleaning, we should not touch. And loading time also, we are not touch the needles or this thing. And this rubber also, after cleaning, we are not supposed to directly touch that areas. Alcohol swab also, we are not supposed to touch the center part of the alcohol swab. So whenever we are taking the alcohol swab, the last corner of the alcohol swab hold and keep on that hub and hold the corners and clean. We are not supposed to directly touch the alcohol swab from center part. So this all the ANTT techniques are very important when we are handling the central line, especially when you're doing this sampling, whatever you're doing, we should not, even though if we are wearing the sterile most gloves also, we are not supposed to test that key areas. And next, this video, a short video, I'm going to show you safe infusion practice. This is called as scrub the hub. So whenever we are touching the hub, the key areas, that has to be clean with the spirit soap, then only touch, use. After using also, we have to clean the soap. So these are the key areas where the hubs are there. Before touching that area, clean with the spirit soap, then only handle that area. So before the first step is hand rub, before hand wash and hand rub. So after opening, again we have to do hand wash. Wear the sterile gloves. The gloves techniques are very important. When you're wearing the gloves, you're not supposed to touch every area. Sorry, that video again I have to play you. The fifth step is scrub the hub. So at least 15 to 20 seconds, we have to see these are the areas, very key areas we are not supported directly. So that has to be scrubbed 15 to 20 seconds thoroughly. So again, we are not supposed to touch the center part. From the outside, we have to hold, clean that area for 15 to 20 seconds. After that, here also, when we are connecting, we are not supposed to touch that area. Maintain few gap between, give the medication, and pushing also, how we have to push directly, not forcefully. So this is the technique we have to push. Push pause technique. So push pause technique we have to use. We are not supposed to directly push. After giving the medication, again, clean that area with the new spirits up and close, wrap, and keep. So this is the very important part, maintaining the center lines. Next thing is the changing of the kinetic set. So as per our policy, we will change 3 days once we are changing. But in between, if anything leakage or any damage is there in the tube, immediately it has to be changed. Especially during giving the chemotherapy or any condition regimen medications when we are giving, during that time, any leakage was there, any leak outside happened, immediately it has to inform to doctor and we have to replace the dose what we have lost. And the main thing here, when we are changing the tube connections, we have to completely prime the tube. So there should not be any air leak inside the tube. Completely prime the tube, then only we have to connect the medication. Keep in your mind very clearly, If anything, patient is getting Lasix infusion or any inodropics, in that situation, in that medication only, we have to completely prime. We are not supposed to prime with the normal saline, then we are not supposed to connect the Lasix infusions. So always any important infusions we are giving 1 ml, 2 ml small amount, it has to directly connected here with the chest wall where the three-way has to be connected. There we have to prime with that medication, you have to connect. The fluid line has to be connected separately with the dual connectors. And we have to use the microclave connectors, and sterile gauze piece has to be used for wrap that one. Also, this blue wrap also we can wrap in that areas. So overall, this procedure, maintaining the ANTT techniques are very important. That has to be closely monitored. Also, as I mentioned, safe infusion practice. Scrub the hub is very important. And especially after doing the tube changing, many times we have seen the tube will be lying, as in our institution, we are using the long tubes. Sometimes it will be laying on the floor. This all the leads into infections. Always it has to come from the above, and we have to make sure it should not stuck anywhere. If somebody is stuck, if patient pull out, that tube may come outside. So that all the areas we have to closely monitor. The next thing about the CVL patency check. So this is very important. Keep the first of all, the important in our setup already we are doing. So we'll make sure to run the fluid continually, because frequently if I'm going to block the line again use the line, there is a high risk to get infections. So if we want to use that line, run continue for 24 hours with a slow amount of fluid. If the no indication, if we no medication at all, only boost sulfon such type, or patient may have fluid overload, no using the central lines. In such type of cases, we can do the block the line. Always keep in your mind when we are blocking the line, we have to maintain the positive pressure is very important. So if you have 2 ml of block, push 1.7 ml, remaining few 0.3 ml make in syringe to be there only, and immediately lock the clamp. So then it's going to maintain the positive pressure. If you're going to push completely, then if you remove syringe and clamp, the blood backflow will come, the negative pressure will happen, the tip may get blocked. So always keep in your mind the positive pressure is very important. Sometimes we also have done antibiotic locks will be done, but especially in our setup we are not doing more. If any suspecting of infection such type, we will do the antibiotic lock. So that has to be very clear instruction from the doctors we have to get, then only we have to follow that thing. Always use the syringe capacity. So when we are going to use a central line, any blood sampling, anything to be used, always use a 10 ml syringe, flushing, blood sampling, everything. Because if you are going to use a smaller syringes, there will be high pressure will be there. There is central line may get rupture. If you're going to be bigger syringes, we cannot push that one. The standard size what we are using, the 10 ml syringe is the best standard. And if the central line is not at all used, we can heparins the line. Once a week we have to use, especially the patient is we are sending home or discharging the patient. Such type of patient, if we are discharging means the once a week we have to change the heparin solution. Okay. In our setup, no issues. We are getting the prepared heparin solution. Is many places they will prepare themselves. They'll put normal saline. They'll put the heparin. This everything. So this all the things are high risk. The patient may get infected with storing and keeping everything. Always when we are doing heparinase, use a fresh Eplox solution. Load and close that one. So these are the about the pathogen check. So next thing about the blood sampling. So before doing the procedure for all these things, hand wash is very important, and maintaining the ANTT techniques are very important. And infusion, before doing any sampling from the central line, whatever medications or infusions are going, that has to be completely stopped. Especially the fluids when we are giving, when you're taking electrolytes, electrolyte imbalance may come. So always stop the medication and then only do the sampling. So again, I don't want to go very deep on this procedure. Do the hand wash, required item has to be there, wear sterile gloves and use the gauze piece, hold the connectors and open that one. After opening, clean with the alcohol swab. Completely the hub has to be clean with the alcohol swab. Once it becomes dry, then connect the 10 ml syringe. After connecting the 10 ml syringes, you should have 3 syringes. The first syringes you're going to withdraw, that is called as discard sample. This discard sample has to be used for only for blood grouping or blood culture can be used. Other than that, we should not use for anything. And we are not supposed to push that blood back into the tube also. That has to be discarded. The name only is the discard sample. The next syringe, we have to connect again, take the required amount of sampling. Whenever you are going to do the blood sampling, first of all, be very clear how much ml to be taken. Because again, you've taken 2 ml, again come back, again it's not sufficient, again you should not go and take. So when you're taking, make sure required amount of blood has to be taken. Also consider if the patient is hypovolemic shock or anything, we're not supposed to take more also. So what is required amount? Take that required amount, take. And after that, one syringe has to be loaded with normal saline, where we are going to flush that line completely clearly. We have to flush that one. After that, clean with the spirit soap, then reconnect the tubings. If the continued fluid is not there, then we can heparinize that line and close and keep. So this is overall about the blood sampling. What is important? Stop the fluid, remove the connector, clean with spirit soap. Discard sample should not support to push back again, and required amount of blood has to be taken multiple times. Again, we should not go and take. After sampling, flush with line, aplock if needed, clean that scrub and connect the regular connecting tube. So this is more about the blood sampling. Thrombosis, how to prevent the clots. So many times we have seen the central line will get blocked, thrombus will happen. How to prevent it? The one is, the first important part is, when we are doing the heparinase, we have to make sure to do the positive pressure heparinase. That is very important. Next thing, always we have to give concentration for the central line pump alarms. So many times occlusion alarms will be coming, the central line getting blocked. So nobody will see. Again, finally, after 1 hour, half an hour, if you see, the central line will get blocked. Central line is very important in the transplant. During the transplant, mid of the transplant, if anything central line get blocked, we cannot so easily put other central line. Again, this is going to directly affect the management of the patient. Next thing is, if the continuous fluids are not there, is there, continue run the fluid. If not there, happens that like. Last part is, during the blood transfusions, especially PRBC transfusion, marrow transfusions, we have to be very careful, because this is a thick fluids where the central line easily get blocked, block will happen. So during this transfusion, we have to be closely monitor. So now the block happen, how to handle that part? So first of all, block should not happen, but if anything happen, how to handle? First of all, stop all the fluid going medications, medic fluids, everything, clamp it and do the hand wash, AND technique, everything. Open the tray, disconnect the continuation fluid infusion, clean with the spirit soap, connect the 10 ml syringe. We are not supposed to push. If the clot is there, we are not supposed to push. Withdraw. We have to withdraw, and slowly, gently we have to withdraw. If it's not coming, use some heparinase solution or soda bicarbonate. In that also we can just push, pull, we can do. But however, we are not supposed to completely push front. If the things are not working, then immediately it has to be informed to doctor. During this situation, don't become panic. The problem here, suddenly people staffs will become panic. We may unhygienically test the central line, not doing hand wash, unsterilely we may test the central line. We may give the infection to patient. After giving the infection, whatever, if you do the central line, securing the central line, no use. However, we are going to remove the central line. If any problems happen, block, maintain very sterility. Even though if you're going to do success in that part also, that line has to be used for future. Unsterilely, if you do everything, the clot removed, everything happened, if the patient gets infection, fever, however, we are going to remove the line. So be maintained sterilely. So if things are not worked, immediately inform to doctor. Sometimes doctors may ask you to use urokinase. Till now in our setup, we have not used that one. If you're going to use the urokinase, gently we have to push 1 ml inside that one. After pushing, clamp that line and label it as a urokinase has been installed. Wait for 30 minutes to 2 hours. After that, again, we have to withdraw. So again, the streptokinase, urokinase is the one of the anticoagulation medication where, especially in our patient, low platelets will be there. It's a very high risk to use this medication. If anything goes inside, patient may start bleeding all over the body. So after 30 minutes to 2 hours, again, disconnect everything, take a syringe, start withdrawing. If when you're withdrawing, when the blood is coming, at least 5 ml of blood you have to completely withdraw, then flush that line using sink. If the things are not gone right, if things are, if again block is not open, label that part, inform to doctor, then we have to remove that line, no use of that line. Next part is about the CVL damage. Whenever the CVL puncture and leakage will happen, accidental removal will happen. So especially when you're handling the central areas, always don't take any sharp materials or scissors. The problem is mostly in the hub areas, we'll put the thick gauze piece and we'll tightly they'll put the micropore. Sometimes nurses will take scissor to cut that micropore. By mistakenly, they will cut the central line. So you have to be very careful whenever you're using the removing the micropore. First of all, micropore has to be secured very clearly. One side opening has to be there. Easily it has to come outside. So always don't use the any sharp item near the center line. Next thing is puncture, leakage, or accident removal. The patient may pull out, it may cut in between. But however, I cannot tell it will not happen. If it is happen, what to do? If it is anything central line got cutted here, this is the thing. Because this is the tip of the central line is the in the superior vena cava. Whenever heart pump, whole blood may come outside and very fastly flow will be there. And second thing is our patient's platelets will be very low. There is a high risk of getting severe bleed. If anything by mistakenly, if anything cut, anything happen, always immediate, don't become panic or don't become run away from that area. Fold this tube, take a artery forceps, clamp that area. After doing that only, then you inform to doctor whatever action to be taken. If you go start informing doctor, all the blood will come outside within a few minutes. So immediately clamp that part, then inform to take doctor, inform and take action. If anything accidentally patient completely pulled out the line, so in that time you have to make sure to give two major pressures. One is neck area to give pressure, one is chest area. Because in the neck area only where catheter is inside in the blood vessel, it will start bleeding here. So give pressure here, do the dressing thoroughly, take a help from other nurse, give pressure, immediately inform to doctor. And during this whole thing, anything accident removal happen, sometimes we may need to give platelet transfusions also if patients are low. So overall, immediately take inform to doctor, take a necessary action for that thing. Next part is CVL removal. So the criteria for CVL removal, the platelet has to be maintained, normal platelet. So generally the platelet engraftment, what they will tell me is more than 20,000 for last 7 days in transfusions will not be there. But in our setup, more than 10-15,000 counts are coming up gradually. We are removing the lines. So that is the normally we are removing the lines. Next is severe infection. If anything infection happened during the procedure, during the transplant period, that time also we are going to remove the line. During the thrombose, we'll remove the line. During the damage displacement happen, we are going to remove the line. Other than the normal removal, any other removal we are doing means always closely monitor the platelet. If generally that all the removal, platelet transfusions are very important. So if you're going to remove with the low platelet, give one transfusion. If you're going to give 3 RDPs, give one transfusion before removing. During removing, give one RDP, and after removing, give one RDP. So that I should make sure to. After removing, closely observe that area for 30 minutes. Closely keep eye, any oozing, any bleeding is there, immediately inform to doctor. If anything suspecting of the central line infection, then we are removing means that tip has to be sent for the culture. The sterilely the tip has to be taken and sent for culture. Other than no, we can discard that thing. And as I mentioned you before, 30 minutes at least closely we have to monitor the exit site. This is the paper what we have published through Sankal, where effectiveness, cost effectiveness of removal of tunnel central line with the anesthesia or short anesthesia, local anesthesia, short anesthesia. In our setup, we are doing all the removals under the local anesthesia, where we are giving Xylocaine injection, immediately removing. Many centers still they are doing in the short anesthesia. Sometimes they will take to OT, they are removing. That all the very high cost will be there. But the very best practice what we are doing in our setup with the local anesthesia without any complication, we are removing. However, after removing, we have to closely monitor and we have to see the any issues are there for patient. Next last part is about the documentation. So this all the management what I talked now, documentation is very important. So CVL assessment. every shift, when nurses are coming for duty, when we are going, go check the central area very clearly, any redness, any oozing or any itching is there in that area, or any tunnel pain is there. So this all the things closely monitor. Also talk to mother whenever patients are getting fever. How is the fever symptoms? Is it looking like sepsis symptoms, or patient is going to hypotension? This all the assessment closely we have to monitor and document and inform to doctor. And what are the important things we have to track? Last, when dressing was done, when is the next dressing? When is the last tube changing was done? When is the next tube changing to be done? When was the last appendage was done? Next, when we have to do the appendage. This all that important documentations are very important. Also, what culture sample has turned from the tube or tip. So that has to be followed very closely. So if the patient has suspect of incest, is it we are giving the antibiotic? So ticoplanin generally covers the gram-positive organisms, especially in the central lines are used the central line infections. We use the ticoplanin, and other lot of things are there. Basically, we use for the ticoplanins. So this all the documentations are very important in our nursing note, and communicate with the doctor wherever you have concern related central line, wherever you have doubt, talk to doctor, get a clarification. Next part is about the assessment. So there are multiple sites, three format I have mentioned. So in our setup, we are using first set where CVL arrhythmia. So this all the documentation when you're doing, don't do something copy paste somebody's other notes. Really think, is it any redness is there, any swelling is there, any discharge is there, any thrombophlebitis is there, block, fever, how long central line is there, are we using TPN, when is the dressing due? And see now here they are mentioned no arrhythmia or pain. Here they are mentioned redness in the thing. So no meaning for this thing. So whenever we're doing the assessment, closely monitor. Closely monitor. If any redness, anything is there, immediately inform to doctors. So these are the three mainly infections will come in central line parameter, where first is called CLABSI, central line associated bloodstream infection. This is purely by the hands of nurses, because from this line, doctors or ANM or nobody is giving medication. We are giving the medication. Whenever we are not following the aseptic precaution, the catheter inside the central line infection will reach, and patient will get the CLABSI infection, very dangerous infections patient get. Next thing is about the tunneled infection. So you can see this red line. So during the insertion time or anything exit side infection happen, the infection start passing inside here. So tunneled infection will look like this. Generally, the first infection will happen in exit side. This is called as the exit side. As the exit side redness, pus will start, and then it will start traveling towards the tunnel. So this is red line is a tunneled infection. So this is all the important part. Again, I'm repeating, catheter site infection mostly will come from us, where we are handling that line. You have to be very careful. Tunneled infection and exit site infection, there is a chance sometime in procedure wise in OT something went wrong, there is a chance to come. But after a few days of thing, again, later it comes, means it's very clearly from our dressing properly not happened, the infection has gone entered. So overall, the conclusion for my today's topic, central and management is equally important as a condition regimen what cell dose we are giving. If we are not going to maintain the central line properly, there is a high risk to patient to get infections, and that infections are going to affect completely outcome of the central line. So anybody has any question? So thank you. I've done with my presentation. Just I'll go for poll.